Hi, I'm Dr. Chris Barrett. I am a podiatric surgeon, and for the last 18 years, I have spent my career working in and managing hospital-based outpatient wound departments. I'm currently the program director for 2 outpatient wound care programs for the Crozier Keystone Health System in suburban Philadelphia. So in the following short presentation, I'd like to take a brief look at the current state of outpatient wound care in this country, some of the challenges we face as wound care providers, and offer a potential treatment approach, which is the first-line use of negative pressure wound therapy, the early use of negative pressure wound therapy, that can potentially help you not only thrive, but potentially survive in your clinic or office if, or more likely when, the definition of a successful wound care program dramatically changes. So just some housekeeping and my disclosures. So whether you practice in a hospital outpatient department or your office, you're treating chronic wounds the majority of the time, right? So you may think, what's the rush? What's the urgency? We can take time, try some different products, some different interventions that I like, but there's some facts that I think I need to share with you. So here's one. The 5-year mortality rate for a patient, a diabetic who develops a foot ulcer, it approaches 50% in 5 years. So think about that. Almost half of your diabetic patients who develop a foot ulcer will be dead within 5 years because of complications from that ulcer. That's higher than breast cancer, prostate cancer, and Hodgkin's lymphoma combined, okay? Patients with venous leg ulcers, the most common wound we see in an outpatient department. Patients with VLUs report high rates of depression, hopelessness, and isolation. Studies have also shown that providers in hospital outpatient departments often choose treatments based on ease of use and reimbursement instead of the cost of the product and the effectiveness. In fact, there was an article titled, "Why Can't We Do the Right Thing in Wound Care?" So failure to follow best practices and provide optimal evidence-based wound care often results in what we call outlier patients. These are patients with stalled wounds that remain on your clinic schedule, clogging your clinic schedule, preventing you from seeing new patients in your clinic. And they also consume a great deal of clinic resources, and they increase payer spending. And believe me, the payers, this idea has not gone unnoticed. So as a result of excessive waste in the outpatient wound care clinic and office, Medicare spending has been estimated, and again, grossly underestimated, but estimated approaching $100 billion. Okay, and these are in 2014 dollars. And this has led to more restrictive wound care policies and reduction in reimbursement for the more popular high-value procedures. And we've all seen that. So any of us in outpatient wound care know that this currently exists. And the experts also predicted the payers are going to introduce new reimbursement models, okay, and policies that are aimed at rewarding providers that can provide better evidence-based care and get quality outcomes at a lower cost. Okay, so the question is, what can I do in the outpatient clinic to improve healing, reduce costs, and reduce those outliers? In other words, the question is, what's your strategy if time and cost really matters? So here's a strategy. Here's my idea. Number 1, more effective patient-centric wound assessment. Okay, that means focusing on the patient first. Focus on the quality of your care versus the quantity, the number of patients and the number of procedures. Get the proper diagnosis, and whatever that takes to get the proper diagnosis, whatever testing that takes, because the most important thing is we start treating the proper diagnosis early on with a better treatment plan, multidisciplinary team, and not just in the clinic, but bring in a team that's going to provide the best holistic care for that patient, address underlying causes, okay? After that, then we can focus on the wound, okay, and addressing the barriers to wound healing. What is that concept? It's the concept, it's the idea that what our interventions, what our goal is wound bed preparation. And we've heard the time principles of wound bed management, looking at the 4 barriers in the chronic wound, which is non-viable tissue, infection and inflammation, moisture imbalance, and a non-migrating wound edge. So some of the things we can offer or we can do to ensure rapid and optimal wound bed preparation, see our patients more frequently, debridement more frequently. Why is that so important? Because we know that bacteria live in a biofilm state in the chronic wound. More frequent debridement, more effective debridement opens a window of opportunity for our interventions to be more effective. We know that not only is our focus on wound bed preparation, but it's maintaining the proper trajectory of wound bed preparation, of healing. We know that in a diabetic foot, that means trying to achieve 50% wound closure within 4 weeks. Okay, so one of the most effective interventions for accelerating wound bed preparation and achieving that trajectory, and really the focus of this discussion, is negative pressure wound therapy, because negative pressure wound therapy is a technology that's been in existence for over 20 years. It has unquestioned evidence and efficacy. And today, we know that when negative pressure wound therapy started, the devices were rather bulky, okay, and they required electricity, some type of electrical source. We now have a portable, lightweight, disposable, ambulatory version of negative pressure wound therapy, ideal for the ambulatory patient in the outpatient clinic and office. And this is known as the SNAP therapy system. Okay, so what I'd like to do is, when I talked about what's your strategy, this is my idea, and this is really the focus of our discussion, using negative pressure wound therapy earlier in your treatment regimen. So let's look at some case studies that demonstrate the effectiveness of using negative pressure wound therapy earlier versus later in the treatment course. So our first case, this is a 48-year-old female with, as you can see, severe lipolipedema with a chronic stalled wound, a desiccated wound. So my recommendation when I saw this patient was not only more effective debridement, but let's add negative pressure wound therapy via this SNAP therapy system, okay, which again, for an ambulatory patient is an ideal way of providing them the benefits of negative pressure wound therapy. So in 13 days, okay, by adding nothing more than negative pressure wound therapy to this patient and frequent debridement, in other words, we're seeing this patient frequently, we're changing the negative pressure wound therapy dressing and debriding the wound. Not only were we able to achieve wound bed preparation, as you can see on the right-hand side, that wound is ready for closure, but we reduced the overall cost of our dressings and reduced the overall cost of nursing care. So again, achieving wound bed preparation in a short amount of time with minimal cost is really the goal. There should be really the focus and goal of your treatment plan. Let's look at another patient. So this is another interesting patient, 57-year-old male. He's a HVAC repairman in a manufacturing plant near our clinic. He had suffered a suspected venomous insect bite to the left forearm. So following incision and drainage of this wound, as you can see, he has a very large cavity wound on the left forearm. So this gentleman wanted to continue to work. He did not want to go on disability, and he would not be able to bring a powered negative pressure wound therapy device to his place of work. Thankfully, we were able to provide him the needed benefits of negative pressure wound therapy to reduce that cavity size. We were able to do that in a form that he was able to work with, and that is the SNAP therapy system. So, and in 10 days, as you can see, we achieved wound bed preparation. So again, we shortened that wound bed preparation time, and he only required a total of 5 weeks to completely epithelialize this wound. But his consumables were only limited to a silver alginate dressing for 1 week, some bordered foam dressings, moisture balancing dressings to achieve complete closure, and only 6 SNAP therapy dressings. Okay, so let's look at another case. So again, the goal here, don't let patients become outliers, okay? And this is a perfect example. This is your typical diabetic foot ulcer, Charcot midfoot ulceration. So this patient had a very small wound that didn't drain very much, so still can get use the benefits of negative pressure wound therapy. But unfortunately, this patient was treated with just standard wound care and offloading with a total contact cast. And you can see that the patient initially improved, but then stalled after 74 days. So all we did differently is not only aggressively debride the wound, but we basically revised the wound. We took a chronic wound and turned it, chronic stuck wound, turned it into an acute wound. Okay, and then we added a commercially available cellular tissue product and bolstered it with the Bridge SNAP therapy system dressing, as you can see, and then offloaded the patient properly with the continued use of the total contact cast. And you can see that within 8 days, the patient went on to complete closure. So under ideal circumstances, if you think about it, this patient could have been started on negative pressure wound therapy, use it early on, and your outcome is going to be far better at lower costs. So when you think about it, the overall clinical and economical gain you can get from reducing the number of outliers in your clinic. So by getting this patient out of our clinic, we're able to get a new patient in and get started on another treatment regimen. So, our take-home message, why wait for negative pressure wound therapy? Okay, it's not just for large, heavily exudating wounds. Smaller, low-draining wounds, ambulatory wounds that we see in the outpatient clinic are ideal wounds to the benefits of negative pressure wound therapy. Really should be considered first-line therapy, a first-line dressing. It's off the shelf. You can use it on day one, following your initial debridement. There's no requirement to wait 30 days to provide 30 days of standard care before you can use the device. And it's ideal for the patients. They prefer it. It's discreet, it's silent, it doesn't affect their quality of life, it's hidden under clothing, and it's low maintenance. So again, my take home, rethink your treatment strategy for the future, okay, which is going to be low cost, moving patients out of your clinic so that we can, appreciate the economic benefits of seeing more patients in our clinic. So I say thank you and happy healing.